before this paper, actually, very few people doing this way. I mean, I'm surprised. I mean, why there's no, because we found the fusion gene about 10 years, 10, maybe 10, 12 years ago. But we didn't look into the blood and serum until like 7 years ago, and we published it. And then we say that, okay, this fusion is very detectable. But the moment we didn't think about making a diagnosis yet, we just, okay, this detectable. That means the cancer cells shedded those transcripts to the blood. We know that it's there. I mean, basically basically a beacon indicator that there's a disease cell there. I mean, the cancer cell there. At least say that we come chromosome recombination there. So we need to do something about it. Then later, actually, we get funded by university the science translation, clinical and science translation centers to do the I think we see whether make a diagnostic tool or prognostic tool. So we just make a screening tool that basically based on a set of cancer that on they give me two sets of cases. One is like before 2015, the other one is up to 2015. And then those we said, okay, we just take the 2015 and before as one cohort and do a machine learning analysis, basically leave an our model, and then after that, and then log the algorithm, and then use that algorithm to predict those cases collected after the 2015, which is, I think the significant number of those individuals are not non-cancer. Actually, they have like cirrhosis, alcoholic liver disease, NASH, or hepatitis B and C infection, those stuff. But there are no disease yet. And versus those who actually has. And we found they're actually quite interesting. Means they are very different. I mean, now some of those folks actually has a cirrhosis and has steatohepatitis. They actually have some of those like low level fusion in there. So my suspicion is that even though it did not reach the threshold as the one who had cancer, they may actually have some cell there already undergone the chromosome recombination. Whether cancers or not, we don't know, but at least I mean that they have some cancer condition like this. So it's interesting. You found those situations. I think about it maybe later. Actually, we will actually look at those cohort individuals which has P threshold condition, but we know that they have children in there to see whether we follow on those guys and see what happened over the years, see whether they develop cancer or not. So that's an interesting try. Probably later we'll embark on those kind of investigation. First thing we do actually is know just entire diffusion alone. The other one, it seems that we have interesting. When we look at the data, we found that some of the fusion gene is usually a negative negative in those high alpha protein levels. So we think they are complementary. Even though most of the fusion gene positive one, the alpha protein is in negative. That's interesting. So when we combine them, see what happened. In that, I found actually surprising. Actually, we see that the complement is so good. I mean, so in the training cohort is 94.8% correct, and then go to the testing cohort, basically 95%. But actually, not only just that two fusion gene model, we have the 4 fusion gene models, 3 fusion gene models. They all work good. I mean, it's just like we have like over 300 machine learning model. Actually, most of them, which means has the prediction rate above 90%. Think about that. So actually, it's just the two fusion model is just one representative. And in fact, many of those actually, in fact, maybe at least like 20 or 30 of them actually reach similar level. So there's a powerful things about the machine learning. Basically, you could utilize it and then able to utilize it. It means able to predict the cancer in a clinical setting. Well, of course, I would like to have more like multiple centers and send us samples like that. That would be nice. That would, but so far I'm pretty confident it's almost ready for the application in the clinic, because we had two cohort. We actually in the previous paper, and we also won about 114, maybe 120 samples. I mean, ish. And then this one is 138. So basically, together over 200 cases. Now, if and I mean, now one thing we do not do actually is focus on specific cirrhosis. We actually those normal healthy individuals, not so healthy actually, they are somewhat variety liver disease, but not just specific, because we found actually significant number of those liver cancer actually coming from those cirrhosis background, like 20% of them. So actually, why don't we just look at all of them and see what happened? They're all liver disease, but some of them actually are precancerous. We would like to probably sometime later we want to like push this one in the clinical setting as soon as possible, save some life, because I believe this, at least in my opinion, is pretty powerful tools to detect the cancer. And it's very straightforward because we only need minimum amount of blood, I mean, the material. Basically, in fact, even though, okay, a lot of tests actually require like very high stringency, like it has to freeze at -80, -20, and frozen sample to see it in the RNA level. We don't, actually, in this case, actually, the blood should stay around a little bit time, I mean, a couple of days in the room temperature, still okay. So that's, I think, it's an interesting thing to do. I think it would be really helpful to reduce the mortality of the disease.